Well, good morning, and thank you for the opportunity to present to you the reduction in late mortality among 5-year survivors of childhood cancer. This is a report from the Childhood Cancer Survivor Study. The improvement in cure rate for childhood cancer really is one of the success stories of modern medicine. If you go back to the 1960s, less than 30 to 40% of children would survive their cancer. Currently, over 83% of children will become 5-year survivors of their malignancy. With that, there's a growing population of survivors. It was estimated at 2013 there were over 400,000 survivors in the population, and that by 2020 there will be over 500,000. However, these 5-year survivors, as they move forward, are still at risk for late effects and late mortality. We've shown previously that these 5-year survivors, even after hitting the 5-year time point, 18% will be deceased by 30 years from diagnosis. Thus, strategies that reduce late effects by reducing treatment intensity have been utilized now for several decades in an attempt to lower mortality rates and improve quality of life. The results from this study come from a population called the Childhood Cancer Survivor Study. This is a cohort funded by the NIH since 1994. It's a retrospective cohort. All survivors were diagnosed between 1970 and 1999 from 31 different participating institutions. To be eligible, they had to be alive at 5 years from diagnosis and diagnosed with one of our common pediatric malignancies. Importantly, with this cohort, we have detailed treatment exposure information, so we know detailed cumulative dose chemotherapy and detailed organ-specific radiation dosimetry. For more information, you can visit our website. In regards to late mortality, so death beyond the 5-year time point, we now show that at 15 years from diagnosis, the 15-year cumulative mortality for survivors diagnosed in the 1970s was 3.1%. But if we look at survivors from more recent eras, survivors diagnosed in the 1980s, their 15-year cumulative mortality is 2.4%. And this is death due to other health-related causes. That includes death due to late effects, and I think that is the punchline, is we're dropping this death rate due to late effects. And most recently in the 1990s, that rate for survivors diagnosed in the 1990s, their 15-year mortality rate due to late effects is 1.9%. Now, what's causing that? When we dig deeper, we can see specific reduction in deaths due to subsequent neoplasms. These are not deaths from their primary cancer, but a second cancer down the road as a result of the treatment of their first cancer. We see reduction in subsequent neoplasm death from the 1970s, 1.8 down to 1%, cardiac death, 0.5% down to 0.1%, and pulmonary death. We wanted to look and dig deeper beyond looking at the global population to specific childhood cancers, and I'm going to report on acute lymphoblastic leukemia, Hodgkin's lymphoma, and Wilms tumor. Death due to late effects were reduced in all 3 of these common malignancies. In the 1970s, death due to late effects for ALL was 2.8%. That's been reduced to 1.9%. Hodgkin's lymphoma, 4.2 to 2.1%, and Wilms tumor, 2.2 to 0.4%. We then wanted to connect the dots between this reduction in mortality and the reduction in therapy that we know has occurred across this time periods. And I'm going to show you an example for acute lymphoblastic leukemia. We developed a scale for treatment intensity, and you can see here that treatment intensity dropped substantially from the 1970s to the 1980s in ALL, largely as a result of reduction and elimination of cranial radiation for this population. Simultaneously, you can see a drop in the 15-year cumulative mortality across this time period as well. And in the plenary session, we'll go into more detail on how we've associated those two. But it's important to know that specifically cardiac mortality and cardiac late effects are an important long-term effect of cancer therapy. Cardiac mortality is decreased in all 3 of these groups, ALL, Hodgkin's lymphoma, and Wilms tumor. And death due to subsequent malignant neoplasms is reduced in Wilms tumor. So in conclusion, we can state that the CCSS cohort provides evidence that survivors in more recent eras have a significant reduction in late mortality. And for the first time, we've been able to attribute that to fewer deaths from treatment-related causes, or fewer deaths from late effects of the primary therapy. This includes lower death rates due to subsequent malignant neoplasms and cardiac mortality. Thus, the strategy of reducing the intensity of therapy to lower the occurrence of late effects, along with promotion of early detection and improved treatment of late effects, has now translated to extend the lifespan of our survivors.